I am honored also to moderate the first session presented by Professor Ashraf Reda, President of IAVA. Dr. Ashraf Reda will shed light on the current status of familial hypercholesterolemia in Egypt, which is a very important matter that is concerning our country. Please, Professor Ashraf.
Well, thank you, Professor Atif, and I would like to welcome you all in this fifth wave of IAVA Casebox wave, which is in collaboration with the ACC Case Report. I would like to thank Said Farag and Julia for their sincere and continuous interest in preparing for these very interesting sessions. I would like to thank Sanofi for sponsoring the first session symposium. I will present some data about familial hypercholesterolemia, both globally and some data from Egypt. Actually, when we talk about familial hypercholesterolemia or genetic cardiovascular disease in general, we know that to have genetic disease affecting the cardiovascular disease, it either be monogenic disorder affecting one gene, as you know, in case of heterozygous or homozygous familial hypercholesterolemia, which can affect LDL receptor gene, ApoB receptor gene, or PCSK9 protein. The other way that genetics can affect cardiovascular disease is when we have complex disorders or polygenic disorders affecting many genes. We are born with different risk alleles in our bodies related to, for example, blood glucose, metabolic syndromes, hypertension, vascular endotheliums, and the more risk allele you have, the more chance that you have premature atherosclerosis. Of course, we are concerned today on the rare presentations of monogenic disorders like familial hypercholesterolemia. Actually, if you ask which gene is responsible for these disorders, it is mainly the LDL receptor gene. In 80% of the cases, the defect is in the LDL receptor gene. However, sometimes it may be in the ApoB, in the PCSK9, or even maybe polygenics. And you don't need to do genetic testing to diagnose these disorders. Of course, the genetic testing is confirming the diagnosis. However, by using something like Dutch criteria or other criteria that put in consideration the family history, the history of the patients, the presence of premature atherosclerosis, the lipid profile, and some physical findings like the nsoma and the plasma and arcus senilis. Of course, this could be using this criteria, we can detect a lot of cases of familial hypercholesterolemia, possible, probable, or definite familial hypercholesterolemia cases. If you look at this nice registry of Korean populations, to see the LDL cholesterol distribution in about 35,000 individuals, we will notice that most of the patients or the general populations, LDL is around 100, from 70 to 130. These are here the most LDL cholesterol lie in this area. However, rarely you have some populations with LDL cholesterol above 200s, and as you see, the percentage of patients is here, and many of these patients are probable or even definite familial hypercholesterolemia. Yes, familial hypercholesterolemia. The Egyptian Cardio Risk Project, and this was the first project to give us an idea about the possibility of having a real problem of familial hypercholesterolemia. These projects actually include 31 centers all over Egypt, ICU centers. We included more than 3,000 patients from 2015 to 2018. All these patients are patients with acute coronary syndrome. And the main questions of this observational study was to see what are the most important risk factors among Egyptian patients with acute coronary syndrome. what is the age of onset of patients with acute Crohn's syndrome? And actually, one of the striking results of these projects, which was published in European Heart Journal and in Atherosclerosis, is the prevalence of patients with premature atherosclerosis. If you look at this on your left-hand side, the males, and on your right-hand side, the females patient, Egyptian patient with acute Crohn's syndrome. In male, for example, this blue and orange and gray color, all of them are patients below the age of 56 years old. So below 55 years old is the blue and orange colors. So we have around 47% of Egyptian male and more than 60% of Egyptian females presented with acute Crohn's syndrome prematurely. So this highlighted the issue of premature atherosclerosis in Egypt. So many of our patients have premature atherosclerosis. And as you know, premature atherosclerosis could be explained either the presence of multiple risk factors, because we have high incidence of smoking, obesity, metabolic syndrome, hypertension, and diabetes, and also the possibility of familial hypercholesterolemia, especially at this age group, is heterozygous familial hypercholesterolemia is there and is of concern and should be highlighted to take care of. Was an important paper published in the Atherosclerosis Journal, the overview of the current status of familial hypercholesterolemia care in over 60 countries. The ES Familial Hypercholesterolemia Studies collaborations. And in these papers, we share with some data from the Egyptian cardiovascular projects, and it was quoted from our data that preliminary data from the Egyptian cardiovascular project showed premature atherosclerosis in 47% of men and 69% of women admitted with acute Crohn's syndrome, in whom 50% of those patients with premature atherosclerosis may have really heterozygous familial hypercholesterolemia. If you look at the picture of acute Crohn's syndrome worldwide, on your left-hand side, this is the general population of acute Crohn's syndrome, and on the right-hand side, population with premature acute Crohn's syndrome. And this column represents the incidence of probable and possible familial hypercholesterolemia. Generally, in patients with acute Crohn's syndrome, maybe 20% of the patients may be possible or probable case of familial hypercholesterolemia. However, if we took patients with premature atherosclerosis, we'll notice that around 50% of them may have really familial hypercholesterolemia. So 50% of patients with acute Crohn's syndrome is premature, and 50% of the premature is probable or possible cases of familial hypercholesterolemia. So we can state that in general, around 20% of patients admitted with acute Crohn's syndrome may be actually probable or possible case of familial hypercholesterolemia. And this is very important because if we detect those patients, you can be aggressive from the start in the management. You can start even with combination therapy because it is difficult to reach the goals with only statin therapy in these patients. So we did some post-hoc analysis in the patients from the cardiovascular project to see the prevalence of familial hypercholesterolemia in our patients. As you know, the projects of cardiovascular was not powered to detect patients with familial hypercholesterolemia. However, we have group of patients with premature atherosclerosis and the group of patients without premature atherosclerosis. We have the lipid profile, we have the family history, so all our patients are having ischemic heart disease. So we can say that those with LDL 155 to 250 is a possible. Those with 250 to 325 is probable, and those above 325 milligram per deciliter is definite case of familial hypercholesterolemia. That's how we calculated the possible prevalence in this case, and we subgroup the patients into those with premature acute Crohn's syndrome and those without. And actually, if we look at those without premature atherosclerosis, if the LDL is from 190 to 325, this is possible FH, and if it is above 325, it is probable FH patients. So in general, among our patients with acute coronary syndrome in the Egyptian cardio risk projects, we have around 16% of cases of possible familial hypercholesterolemia and 0.25% of probable and 0.1% definite familial hypercholesterolemia. These are the results in the general population of patients with acute coronary syndrome. I'm sure that if we do the same calculation in patients with premature atherosclerosis, the numbers will be more and more. We was in IAVA incorporated in the important study of familial hypercholesterolemia collaboration studies of the European Atherosclerosis Society. And that was a great opportunity for us to include our patients with familial hypercholesterolemia. So in this study, it could be considered as an Egyptian registry of cases with familial hypercholesterolemia included in the ES registry, including more than 60 countries around the world. And this is some data from this registry. This is the preliminary results of the Egyptian Familial Hypercholesterolemia Research Forum registry. And as we see on your left-hand side, in our patients with familial hypercholesterolemia, we are divided into 30% definite, 12% probable, and 57% possible. And if we look at the phenotypes of these patients, our patients with familial hypercholesterolemia are characterized by the presence of multiple risk factors like hypertension, 30%, obesity, 50%, smoking, 22%, consanguinity, 60%. So our patients with familial hypercholesterolemia seems to be more risky because they have additional risk factors like obesity, diabetes, hypertension, and smoking. And this is a burden for us to treat such patients because they need early detection, they need early treatment, and they need aggressive treatment from the start to trying to prevent cardiovascular atherosclerotic event. This is some data from the registry regarding the lipid profile of our sample of Egyptian patients with familial hypercholesterolemia included in the European Atherosclerosis study. That mean total cholesterol 316, LDL cholesterol 237, HDL 47. Of course, all of these are in milligram per deciliter. Triglyceride 190 and lipoprotein little a 42 milligram per deciliter. Regarding the management strategies or management in this sample of Egyptian patients with familial hypercholesterolemia, the combination non-statin therapy, most of them, or more than half of them, using ezetimibe. However, the use of combination therapy was only in 56% of these patients. Despite that, they are, as I see, high-risk patients. The other observation is the use of PCSK9 inhibitor at that time, couple of years ago, was very low, around 2.6% only of familial hypercholesterolemia patients registry are on PCSK9 inhibitor. That's why we share with European Atherosclerosis Society and the WHO and the other organization of familial hypercholesterolemia Global Summit in writing an important paper in JAMA Cardiology about reducing the clinical and public health burden of familial hypercholesterolemia, a global call of action. That was very important papers, and I think it was the first paper after about 25 years of the first one about call of action of FH patient from the WHO. The important message of this global call of action is the awareness. This is very important because awareness of the problem of familial hypercholesterolemia is very defective among general population, defective among the governmental bodies, even defective among physicians. When a physician see a 51 years old or 49 years old patients in his clinic with a history of myocardial infarction, many of them did not put in mind the possibility of heterozygous familial hypercholesterolemia. And what is the usefulness of putting this possibility? The usefulness is you can screen the family, you can screen his sons and daughters, you can screen his brothers, even his father and mother for the possibility of familial hypercholesterolemia. So awareness also, this is a sample of awareness for the general population, some recommended samples. For example, we can, what is familial hypercholesterolemia? Some simple definitions to put to the general populations. Know the signs of familial hypercholesterolemia, whether some numbers about the lipid profiles, nodules and the xanthelasma, the white ring around the cornea. Also how to treat in order to emphasize the importance of lifestyle intervention, the importance of using combination therapy, and also we have to stress the fact that familial hypercholesterolemia runs in families. So once one is diagnosed, we should look at the other members of the family, especially first degree relatives. There is one important question that need to be highlighted for physicians and for those who are concerned with FH is, what is the best age of screening? Of course, the best age of screening depends on the family history of and the history of premature atherosclerosis. However, some cases of FH, especially homozygous, you can even screen the newborn. But however, all our children around the age of 10 years should have at least lipid profile once in time, and maybe repeated at age of 25 to 35 years of age. Important screening is child parents cascade screening. You know, the usual screening is when you have a patient with familial hypercholesterolemia at age of 45 years old, premature atherosclerosis, for example, you will look at his sons and daughters. However, when you detect a child with familial hypercholesterolemia, you should also do some lab and some investigation, some physical examination to his parents, and this is called the reverse screening or child parents cascade screening. This is very important. However, effective screening is not easy, and we have barriers to effective cascade testing or cascade screening, like, for example, the variation in healthcare and genetic privacy policy, the lack of knowledge and skills among the providers, the poor communications in family to see where is your aunt, where is your uncle, maybe there is no communications, the underutilization of genetic counseling services. It is difficult, it is not available, and even if it is available, it is underutilized, and of course, lack of knowledge of best risk notification methods. Let me finish with these 9 policy priorities that we wrote in the paper of global call of action regarding the FH all over the world. These 9 priorities for improving FH care include creative awareness. This is very important, the awareness, as I told you. Continued advocacy organization around the world provide patient support and education. Also, the screening, the testing, and the diagnosis should be highlighted. The accessible treatment should be easy to access, especially in health care systems, in insurance organizations, and so and so. Also, we need guidelines specific for cases of homozygous familial hypercholesterolemia. Data are very scarce, and we don't have a lot of data to support guidelines, but we need guidelines for homozygous familial hypercholesterolemia. We should organize for family-based care, not only patient-based care, because patients with familial FH has a member of his family have the same problems, and you should take care of all the family, not only the patients. We should have registry and research in this field to try to look at the prevalence, the real prevalence, because we don't know till now the real prevalence of FH in most of the countries around the world. We have a lot of percentages, a lot of numbers, but none of them are accurate. It seems that the problem is more than we realized, and I hope we can put these 9 policy priorities trying to improve the care of FH patients. Thank you for your attention. I leave the microphone to Professor Atif, and I will stop sharing.
Thank you very much, Professor Ashraf, for your great, illustrative, valuable presentation that make us happy with that we have all this data. It seems we have in Egypt a problem. Many unscreened patients with familial hypercholesterolemia and lack of awareness among physicians and the population too. So it's our job as IAVA to spread the awareness among the physicians and people to get good data to manage and prevent premature atherosclerotic cardiovascular disease. Can you shed light on what steps we should do in Egypt here for our population to prevent and to manage FH patient? Is it denying the policy priorities you show for the last slide, or we can do others?
Well, I think because FH in general is rare disease. However, the prevalence of premature atherosclerosis among Egyptian patients is high. And we have to convince the authorities, healthcare authorities, about the problem of premature atherosclerosis. Realize a man of 45 years old with myocardial infarctions, how is the burden of disability, how is the economic burden on him and on the family, the social and psychological burden on the family of having myocardial infarction at years of 45 or 50, even 50 years of age. So we have a problem in Egypt that most of our healthcare authorities thought that, for example, the liver disease is more important than cardiac disease. And I think we have defect in supplying this data to the authorities to convince them that the cardiovascular disease is the #1 killer in Egypt till now, by far, even more than cancers in Egypt. And the prevalence of premature atherosclerosis is very serious, actually, as I showed in our data, that nearly half of our patients with acute coronary syndrome in the intensive care are premature atherosclerosis. I'm sure if we ask about the family history, and if we do some simple tests like lipid profile for the first degree relatives, we can detect more and more. Let me welcome Dr. Julia. Thank you being with us. Thank you for your support.
Thank you. Any question from the panelists?
Yes, I'd like to ask, I will take the opportunity that Julia joined us now. Do you have a submitted cases in the JACC case reports about familial hypercholesterolemia cases? Do you have? Because we are thinking about doing a wave about the familial hyper, because we have a lot of cases. We have a bunch of cases. Professor Ashraf, yes, we have. Yes, we have.
Yes, we have cases of stents in
we have a fantastic cases.
9 years old.
I think, first of all, the prevalence of familial hypercholesterolemia may be much more, there. We have received, I think we have almost approximately 3 to 4 cases. We don't receive cases at the weekly basis. Practically, I think Rafa has handled a lot of cases of familial hypercholesterolemia. Yes, we could do a wave on hypercholesterolemia and maybe, complications.
Yes, I think if you announce that we will do a wave about the familial hypercholesterolemia cases and its consequences, I think you will find in your archive a bunch of cases which will be interesting for the audiences.
That's fantastic. Yeah.
Professor Atif, if you don't mind, we are going to close this session for the current status of hypercholesterolemia. And I think we will now start by giving the mic to Professor Ayman Abulmagd. I think he is with us. He will be the moderator of the first session. Professor Ayman Abulmagd is the professor of cardiology at Azhar University. He is one of the eminent professors in Egypt. He is one of the eminent interventionists also in Egypt and the eminent cardiologist. I think he will give us a nice moderation, a fantastic moderation for the coming session. And I'd like again to thank the JACC case reports represented by Julia Graspa, the chief editor of the JACC case reports, that give us the opportunity to give these educative waves.